So today, okay, all right, now that we're recording, so welcome everyone. So today we're going to talk about treating non-adherence in pediatric patients, and specifically, I think this can go a lot of ways. I think it can go both for mental health, both for general health, and I think it'll be a nice way to kind of see how it all kind of melts together. So the first thing I wanted to talk about a little bit is kind of language. When we're thinking about non-compliance versus non-adherence, just because I think a lot of us in the medical profession have heard both used, right? This patient's being non-compliant versus this patient's being non-adherent. But so I kind of wanted to first leave up Merriam-Webster's dictionary as to how either of those two are defined. So if we look, non-compliance, the definition is failure or refusal to comply with something, such as a rule or a regulation. Whereas non-adherence is defined as lack of adherence. So my question in this is kind of to the group is, where do you think the responsibility is being placed when we use the term non-compliance? And feel free to either answer in the chat or shout it out. All right, no guesses, no one dares? That's all right. So one of the things that I think language matters as we're conceptualizing this, and when we're thinking about non-compliance, right, failure or refusal to comply, is really putting a lot of the onus or the blame on our patients and their families. And that may not always get the whole picture. Whereas lack of adherence, right, could be the patient, could be the family, could be other factors, right? And I think even just how we use those terms, I think makes us look at things differently and looks at our patients differently. And I think is going to affect how we even are conceptualizing where this behavior is coming from. And so that's kind of my opener is language does matter. So I kind of, the way I'm going to set up this presentation is a little bit of kind of how would we think through this if a patient were to show up in your office. So kind of the way I want us to conceptualize today is using the pediatric self-management model. So this was a model created by Modi and colleagues back in 2012. And it kind of looks at different processes and factors, and it's organized across 4 different domains. So what are the individual factors that are leading to non-adherence? What are factors in the family that are leading to non-adherence? Are there community factors? And are there factors that are related to the healthcare system? And all of these interplay together to basically give us our manifestation of what a pediatric patient's self-management behaviors are going to look like. So when we're conceptualizing this way, we want to look for factors in all those areas, but we're going to divide it even further. What are influences that are modifiable for these patients and families? And maybe that's going to be where we're going to want to target our interventions. And what is going to be non-modifiable? So let's get a little bit further into that. So I wanted to, because since we're conceptualizing this, I wanted to give us some solid examples of what some of those things might look like. So when we look at modifiable, what we're really thinking about is what is something maybe that may be a little bit more easy to change than some other things. So when we're thinking about individual factors, it may be that your patient has a lack of health knowledge. Maybe they're just forgetful. Maybe there's time management issues, or especially where you see it in children, maybe there's oppositional behaviors happening around some aspect of their treatment or their medication use. Whereas you look at the other side, some of those non-modifiable factors are age. Unfortunately, 5-year-olds are going to be 5-year-olds. We unfortunately can't change that. Maybe it's going to be something like the race of your patient. Maybe it's going to be cognitive or developmental functioning. Is that 5-year-old actually developmentally acting like a 5-year-old? Are there developmental delays? Are there cognitive difficulties that maybe are going to influence how they might participate or refuse to participate? So maybe those oppositional behaviors might deal with a child who's maybe more functioning like a 3-year-old. And how is that going to influence whether or not they're able to adhere to any treatment plans that we really give them? So some modifiable family factors may be parental involvement. Maybe there's going to be supervision. Maybe is it the parenting style where we might have maybe more permissive parenting, or maybe completely authoritarian parenting, right? And all of those just in mental health cause different issues. And just as much as, for example, a kid might refuse to comply with an adult directive like, oh, I don't want to go to bed. Well, how is that going to translate over if I don't want to take this medication? Some non-modifiable family factors are things like culture. Unfortunately, we can't change where our families come from or how they were raised. Income status is very difficult to change. And even things like immigration status as well. Some modifiable are maybe community factors as well. That maybe the setting where this kid is not that conducive to treatment. It's hard to do it at school. Or maybe there's some embarrassment of maybe I don't want people at the restaurant to see me check my sugar. Or maybe lack of social support. Something, especially when we're thinking about West Virginia, and a lot of our patients is who might be living in a community that has less resources, or even geographic isolation, because that's going to look very different. We also want to think about the health system as well. So what are things of like the cost on a family for those medical supplies or the medication, and even things like rapport. Maybe they get along great with nursing staff, but maybe they might be standoffish towards their physician. And some other things that are less easy to change are also going to be things like their health insurance status, right? Maybe we're on Medicaid, maybe we don't have insurance. And also if they've had any previous negative interactions with the healthcare system. So I think the first start to any good treatment is a fantastic assessment. So when you are running your assessments to kind of find out why is this happening, you really want to look through different areas to get a really good idea. So one of the first places a person might start is just a medical chart review. So first thing, bioassays from current or previous visits or admissions. So that'll give you a sense of how long this has been going on. However, there are some disadvantages to that because one, given half-lives of medications and things, that blood work or that urinalysis isn't always going to tell you if there's adherence or not, right? Other thing is they're also expensive. So that's where a good history will help us. Sometimes seeing previous notes from different providers. Sometimes when I'm checking medical charts, yeah, I'll look through what's gone through mental health, but I'm curious also, what did their endocrinologist say? Well, what's been happening the last few times when they visited GI? You also want to see kind of the patterns of the visits or admissions even. So, have they been keeping up with coming to see endocrinology if a kid has diabetes? Are they coming every 3 months or not? Or if you prescribe psychiatric medication and they're supposed to see you in 6 weeks, have they been making those appointments? You also sometimes what can also help is also looking at some of the prescription refill patterns. It can be really telling if the last time they saw you was 6 months ago, but they only got their prescription filled for a 3-month supply. You also want to get input from all members of your medical team. So maybe some of that evidence about non-adherence is going to come from maybe your support staff or other providers, nursing, front desk. You also, if this is a new patient for you, you might want to check about any past recommendations that have been made or any strategies that everybody has tried to implement before, because that'll also give you a picture also of what worked and maybe what didn't. The next big one, and I think this is probably the meat of it, and I'll devote a little more time to it, is interviewing with the patient and the family. So one, there's a lot of shame that can happen around adherence. I think for a lot of families, sometimes seeing their provider can kind of be a little bit like going to the principal's office because you don't want to get in trouble. You don't want them to know that, okay, yeah, I've been taking insulin, but I've kind of been sneaking cookies at night, right? And what that can often happen is that families are often going to overestimate how much they're really adhering. So some of the stats with that is in pediatric patients, depending on the study, it's been around like 50% adherence. So, and when they get to adolescence, the numbers go really far because it can be somewhere from 65 to 90% of non-adherence. So it really, so again, so it's a little out there as far as any definitive rates. But again, if we go in kind of understanding that, we may want to make goals then that are like, okay, let's see if we can get them to 65%, maybe 80, right? And then, but the one other way is the medical adherence measure. However, I warn you, it is a semi-structured interview that does look at adherence. However, it does take 20 minutes. And maybe that's not the time we have when we're consulting, or as far as kind of your appointment, especially considering everything else that we might have to do. It's available, and it's something people can look into, and there's research on it. But I think we also have to be a little bit pragmatic as well. The other thing that sometimes can also be used is self-report questionnaires. Right now, as the research stands, there's really no gold standard right now of adherence questionnaires. So I've listed some of the following that have been researched. But again, I think something that we always want to keep in mind with self-questionnaires is kind of this social desirability factor. So again, families and patients want to come across as good to their providers. So again, just as how we kind of talked about in the interview, there can be a little bit of that overestimation. You'll definitely see it in any self-report questionnaire as well. But how do we even talk to these families when we are running our interview? So, and I think that's probably practical advice. So one of the first things you want to do is you want to use simple language. I think for a lot of us, and I get it, everyone has a wonderful education, wonderful training, right? Y'all got to where you got to for that. But unfortunately, we get used to talking in jargon, and it may not always make sense to the family. So for simple language, it's maybe kind of like I would like to learn what it's like for you to take your medicine and the way your doctor prescribed it. Or, I see that you don't like sticking your finger. Can you tell me more about that? So the other thing we want to do is normalize these adherence challenges. So a lot of people forget to check their sugar. What's getting in the way, or what's making it hard for you? Or sometimes when I work with diabetic patients, I talk about, sometimes it's really annoying to do the sliding scale for your carbs. Do you ever just sometimes like grab something and eat? Or for me, I also have a love of Coca-Cola. I know I shouldn't have it, but sometimes I can't help myself. I wonder if that happens to you too. So that can allow families to, one, make a connection with you, and also start to open up that conversation of, we're all human. We're bound to forget, we're bound to have our reasons to why we're not going to go with something perfectly. The other thing is you want to be specific. If there's an area of non-adherence that you're really trying to look into and really want to find out more about, it's okay to ask specifically. So how many doses of this medication have you taken this week? Or, is there a meal? Are you checking your sugar at dinner time? Right? So being very specific about what it is that we're asking. The other thing that I think will give you a lot to work with is asking about what is it about their treatment or their regimen that is affecting their lives, and how do they feel about it? Is it really hard that I can't eat dairy anymore? Maybe someone was diagnosed with celiac. What does it mean that I can't have gluten anymore? Is it that, I'm so used to having someone baking me a cake on my birthday, and it makes me really sad that maybe it doesn't seem like a possibility for me anymore. Or, it makes me feel weird to check my sugar when I'm hanging out with my friends at cheer practice. So I think that can give you a little bit more, and it can help you be more thoughtful as far as how do we intervene. Obviously, for those of you guys that are prescribing medications, right? And I think a lot of you do this, but like, what kind of side effects? And even going a step further, is this a side effect that you can tolerate? Because maybe some of us are okay with a little indigestion or all the other things that are listed in the commercials. Maybe I'm okay with a little indigestion, but I really can't handle the headaches. It's worth asking. And also, specifically, again, talk about identifying the problem. So, which of your medications is most difficult? When is it hardest for you to give yourself an insulin injection? When is it inconvenient for you to do a feed if you have a G-tube? The other thing you want to do is you want to use that data that you gathered in the beginning to facilitate a conversation about the adherence. So an example I put here looks like kind of going back to that, the last time we saw you was 6 months ago, right? Looks like the last time was 6 months ago. This lets me know that, like other families, maybe there's some difficulties making sure that our child is taking their medication when they're supposed to. It's something we see a lot, and we'd love to talk about how to support you in this. And again, you want to bring that collaborative stance, right? We want to come across as non-judgmental and really make it a thing that we want to collaborate with you, we want to work with you, and we want you to succeed. So how can we help get you there? Because we are here to help you, not necessarily to judge or kind of be the principal. For those of us with mental health experience, for those of you that maybe are familiar with motivational interview, and then honestly, motivational interview could be an entire other lecture, but it's a specific approach that was originally developed by Bill Miller, and originally it was for substance abuse patients, but it's basically a way of taking a non-judgmental stance and to really talk with a patient and help them kind of understand, why are they doing what they're doing, what their values are, and if there's a way to kind of make that connection that their behavior isn't necessarily going with what those values that they hold are. And if you had those motivational interviewing skills, which I know usually gets kind of taught, especially with mental health programs, that's where you definitely would want to apply. It's just maybe the behavior is a little different. Whereas in traditional motivational interviewing, it may be things like, what are some of the good things about using alcohol for you? Whereas in this case, what's been working for you as far as not checking your sugar that often? It can help kind of having that non-judgmental stance. Having that stance of an open conversation is going to get you a lot further as to finding out what are some of those 4 factors that we're talking about. So for example, if they're not taking medication, is it because terrible side effects? Is it that someone lost their job and they lost their insurance? So maybe they're rationing right now. All those things might come up. So, okay, we did an amazing assessment. We're thinking about how do we help our family or our patient? There's different types of interventions, and not all of them always have to be mental health based. So some interventions may be those educational interviewings, where especially if we have a lack of knowledge, it can help on providing that instruction as to when, why, how does it work. But usually when we tend to see these intervention types, we tend to see them usually at diagnosis and often during transition periods. But sometimes it may help to have it in the in-between. However, education alone is not enough. They're usually some of the best interventions, which we'll get to in a second, have a combination of all of that. We also may be doing behavioral interventions. So those really are targeting what's happening right before and what are the consequences of either following or not following a treatment regimen. So some of these interventions may be things like, starting a reward system or even setting reminder systems, right? So maybe helping a patient use an alarm clock or a phone to have those reminders to take their medication or to maybe do insulin or check sugar. Doing goal setting. And this is where you may want to refer to mental health, is maybe targeting some of those cognitive factors. If you're seeing that this patient is also depressed or anxious, or that maybe you're seeing some difficulties with either coping with their illness or even accepting their medical condition. And that's where psychotherapy referrals can become important. Family and peer interventions actually have been really successful in improving adherence. So one intervention that has been really well researched is behavioral family systems therapy for diabetes. So this is an intervention that kind of combines family systems therapy, communication skills, cognitive skills, as well as education to kind of help a child be more adherent to their diabetes regimen. Functional structural family therapy tends to be really helpful because, again, it's that teamwork and that shared responsibility of following the treatment regimen. Often teamwork approaches have been found in the research to be really helpful as far as sharing responsibilities in asthma management. However, the best interventions, as kind of alluded to, with family and peer are really multi-component interventions. So you want an intervention that targets multiple strategies, which includes such as behavioral, education, and family interventions. And these days, they're some of the most commonly used. Some examples of that are, for example, CBT for chronic pain, which includes education, often behavioral interventions, and often you work with the family in order to help a child or an adolescent manage chronic pain. Another one is CHIRP, or the Childhood Health and Illness Recovery Program. It's an intervention that was started at University of Louisville, but they actually have the workbooks and the clinical manual right now available at like Amazon, Barnes and Noble, and places like that, because what it is, it's a manualized CBT intervention, usually for kids 12 and up, for dealing with chronic illness. And it has really great modules. So some of the things that it includes are like cognitive interventions, stress management, communication skills, which all helps towards a better, and it has been pretty well studied as far as helping out with those outcomes. So, and obviously that would definitely be something that obviously someone with a mental health background can do or recommend as far as therapy. However, coming back to our interview, what are some of these barriers? So let's go through some of them, right? So we're back to Modi's model. So looking at those individual factors. So one may be not wanting to feel different. So some interventions, one, obviously you may want to refer to outpatient mental health services to kind of get at what's going on behind those feelings. But even some things that you guys can suggest as a non-mental health provider maybe can even be things like, maybe we need to plan the time or the location of treatment, right? So maybe we can plan, maybe let's take your medication in the evening when you're back at home and not when it's during school, because you don't want to leave to go to the nurse's office. So those also small adjustments can be made and can also make a difference. Some of them may be things like burnout or low motivation, which often happens, especially when kids have been dealing with a chronic condition for years. They're kind of over it. So that may be things like planning an incentive or a reward system with the parents, right? If you're able to make these healthy choices at dinner, maybe we can get some extra screen time. This is also where you want to do some motivational interviewing, because you really want to get at investigating what are their beliefs about their health, about their illness, about their prognosis, and even about their benefits of treatment. And that can also be addressed with education. And again, thinking about what the patient and the family values, connecting those benefits. So, for example, if the kid is a soccer player and they're on a travel team, how is it that taking their medication is going to help them become a better soccer player? So some of those family issues that can sometimes happen are family stress or conflict. So that may be referring to behavioral family therapy. However, if you're seeing that the source of the stress or the conflict may be something resource-based, like finances or a lack of transportation, that may be, if that's available to you, a social work referral, or even referring them to other community resources. For example, some insurance programs, for example, have transportation services, and being able to connect them to that. And for that, you don't necessarily have to be in mental health. Something to think about is insufficient supervision, which happens quite a bit. So some things maybe doing is educating caretakers on what the appropriate developmental expectations are. You know, maybe we can't expect an 8-year-old to manage their own glucose levels. And that's where you as a provider can help them problem solve around, how can we share this responsibility amongst the family? How can we do this in a way that everyone is available? And that may be, okay, maybe we might have to alter the time of taking medication when mom is back from work, rather than expecting them to do it over the summer when they're with the babysitter. So communities may happen. So an example may be the school may be not conducive to the treatment. So that may be, again, some of that problem solving around times, locations. Something that a lot of physicians are able to do is help the family fill out forms and create that 504 plan. Educating teachers and administration on what this child or adolescent's needs are. There can also be embarrassment around doing it in treatment in front of others. So some of that may be psychotherapy to explore some of those feelings, or again, kind of going back to how can we problem solve this? Some may also be in the health system. So a common barrier is the rapport that we might have between the patient, family, and the provider. So that may be providing support. Sometimes it also helps to bring in other team members, maybe which whom the family has good rapport, or maybe a longer standing relationship. Sometimes that's been really helpful, kind of doing those warm handoffs where maybe they have a great relationship with their family physician. And if they're able to kind of make that introduction of, hey, this is my friend, the psychiatrist, it can often help families also be more receptive. Some other things that you can do is even using your own behavior. So if you're able to model, for example, asking questions about treatment, that can really make a big impact for the family to know that it's okay to ask questions and that they are free to do that with you. For things like health insurance not covering, that may be something that we want to think about community resources. If you're working within a hospital system or referring to social work or case management, again, to help with those financial barriers. And just an extra, because obviously Modi didn't necessarily include this in their model, but there are medication or treatment specific barriers that come up. So some of it may be, for example, difficulty with swallowing pills. So doing a pill protocol is a pretty brief outpatient psychotherapy intervention. It has to do with exposure therapy, but usually those are pretty successful and can help with taking medication. Fear of needles, you definitely would want to refer for brief outpatient psychotherapy, and kind of the gold standard really is exposure therapy. That would definitely be best, and it's definitely the gold standard. But there are all sorts. But those are small interventions that can be done for some of these common barriers, and it doesn't always necessarily have to be manualized CBT treatment. However, that is also an option as well. So really, you want to get a really good assessment going from multiple places, having a non-judgmental conversation with the family, and really working together with them to problem solve these barriers. And if we're seeing that there are things that look like maybe this is anxiety based, maybe we're seeing oppositional behaviors, that's where, for those of us in mental health, we can still apply our skills. It's just a different demand. And that's really how I always like to conceptualize it, because we often are ready to intervene, like, oh, when a kid doesn't want to go to bed, or I don't want to brush my teeth. It's still a similar power struggle. It's still similar behavioral interventions. It's just the demand is different. Maybe instead of brushing teeth, now it's, you know what, I don't want to take that medication. It tastes yucky. So then that's where we can even suggest things like, okay, is this a medication where it's okay to maybe add one of those pharmacy flavors? But these are my resources. And so I know they told me 25 to 30 minutes. So I'm going to open it up for any questions that anybody may have.
Awesome. Thank you so much, Dr. Laura. That was really interesting, and you are just very lively and do such a great job. You're just naturally really good at presenting. I enjoyed the simple questions. Getting on that trust level with the patient, I think, is important, and just trying to understand them. So does anybody have any comments or questions? Way to go. Fabulous from Dr. Swagger. Thank you so much.
And if anyone wants to talk through things, I love doing that. It's one of my favorite things to do.
Yeah, don't be shy. I was like, oh my gosh, I hate swallowing pills. So I think a lot of people could relate to that.
Funny thing is, so when I'm doing pill swallowing protocols, I actually use candy.
No way. Oh my God.
Yeah. So let's talk about it. So one of the funny things I keep, actually, it's right here on my desk. So I think we've seen this at a lot of pharmacies. Is it candy? Gosh, yeah. Is it a pill? Is it dangerous? Right? So sometimes I'll use this, and I'll usually work with the family and the child, like, which one looks like yours? Is it the one that looks like a Skittle? Is it the M&M one? And we'll work through things together. And so sometimes I'm going to start with something as small as sprinkles. Yeah, and I have them as very small as they come. And then these are my biggest sprinkles. And then we have everything in between. So obviously we give them some of those anxiety, obviously, mind you, please mental health only do this, but usually we work through anxiety, right? So we'll do some coping skills, deep breathing. How are we going to, all the things that we expect with dealing with anxiety or for an exposure treatment. And then we kind of work with them, get on making a fear ladder, right? Which obviously the end of the fear ladder would be the closest thing or actually swallowing their pill. And usually we'll start with baby steps. So we'll pick like, okay, which sprinkle are we going to try first? Then next, then next, then next. And then going up with smaller candies, working all the way up to whatever it is that they may need to.
That's awesome. That's really
And
great. You should have done
kids
this.
get a little and kids get a little bit motivated. And obviously I always check with parents first if that's okay. Also check with providers if that's okay, right? Because sugar, we have to be a little bit careful. We also have to think about food allergies. So there's a lot of permissions that go with that too. But that is something that yeah, people do a lot. And again, a lot of that is those good, if you have a lot of familiarity with running an exposure or CBT with exposure and response prevention, again, the stimulus is just going to look different. Whereas maybe we were working on having a phobia of dogs, right? Now it's okay, I'm scared to swallow this pill. So it's definitely something. I think candy for some kids can be pretty motivating because I definitely had that from
Hey,
a
that's
case of
motivating
mine.
for me as an adult. So
I actually did have a kiddo who was just like, wait, we're going to get to have candy?
you're like, yes.
I'm like, yes, but so I was like, before you get too excited, there's a purpose to this.
Purpose to the madness. I love it.
There's a purpose to this.
Does
And
anybody
obviously
have
lots of
examples like
permission.
this? Sorry, go ahead, Dr. Laura.
What?
Yeah,
Sorry, go ahead.
I
What?
was wondering if anybody else had examples like this or how they, connect with other families when they're going through assessments and such. Giving it the echo pause. Heather, go ahead.
I think my experience may be a little bit different in terms of being a clinician and a provider. But when COVID first hit, I was still working in Los Angeles. And at the clinic that I was at, when the vaccines came out for the older kids, our, older teens and young adults, we did an entire, almost like a clinic preparation for them and got the, everything except for the needle to really make it a more of a positive experience to help them prepare to go get the shots. And the parents were so grateful. And I love this. The sprinkles idea. I've never thought of that. And that is such a great idea. I can't wait to share with the PBS team for the families, because it's a positive way to help your child take medicine as opposed to all the other ways that, some doctors that are a little bit more traditional, I think, might recommend. So I love that idea. So thank you for that. But I think, yeah, the shots, or also with dentistry, I think preparing clients to see the dentist and going through like, here's all the tools. This is what it will look like, and letting them touch the tools, so
That's
they're
why
not
I keep a
as,
realistic medical playset on my top.
yeah,
So
yeah,
just for those occasions.
yep.
I was gonna say, how cool. We're in Los Angeles. I did my internship actually at CHLA.
Oh, wonderful. I was with Leaps and Bounds. It's a private agency, and I was doing the social skills program there. And
Very cool.
so my clients were 0 and up. I mean, like, we had everybody. I had an adult social skills program in combination with the tailored services, working with their individual therapists and coaches. And then we provided like after school programming. So the last couple years were crazy because we had to take socialization and put it online to make it work. Because when everything shut down, LA shut down.
Yeah, I was
We
gonna
couldn't go
say,
anywhere.
talk about a barrier, right? It's really
Yes.
hard to do these things if they actually physically cannot get to you.
Yep, exactly. So I was out there for over 17 years. So CHLA though, beautiful hospital,
Yes.
wonderful, wonderful service. My own child has actually been there before. So there's a lot of organizations that support them. They have a really huge financial and outreach too. I think there's a lot of people in the community that donate their time and make an effort to support them too. So
It was a great training experience.
I'm sure. Yeah. Well, thank you. I love these. These are always interesting.
Yeah.
So I love being able to hop on here and join you guys. So thank you so much for what you do.
Of course. Thank you for being here today. Hi, Brandy. I see you made an appearance.
Yeah, I just thought I'd turn my camera on. So
Love it. I was going to say, any questions, comments, things that are coming to mind when we're thinking about adherence? Because, that can also happen even in the world of therapy and psychiatry, right?
yeah, I do. I'm a prescriber role here. So I run into a lot of like geographical challenges, and we don't have a lot of services. Like people have to drive 45 minutes to an hour to the office here. So I have a lot of barriers being in a rural area.
Yeah, absolutely. And then and I think that's probably going to make you super thoughtful as far as, is it really that they don't want to do this? Or is it a
Right.
lack of transportation?
Mhm.
Is it that the pharmacy is too hard to get to right
Yeah,
now?
we now have a service that we will go and get the clients as well. Like we have a transportation system that we got a company vehicle to try to help with the barriers. Because we live in a very rural area and it's really mountainous here. So it's a challenge to get to the clinic.
Yeah, I can't
Yeah,
even
so
imagine.
we
I wonder
we try to work around it. But I love the sprinkles thing.
No
Put it down.
worries.
I was like, I'm gonna
No worries.
because I have a couple of teenagers that they attempted overdose and now they have a lot of anxiety of trying to take antidepressant or something by mouth. So they have a lot of anxiety and flashbacks almost of them trying to do that. And so we have to work through that a little bit with
Yeah.
therapy. We try to.
Yeah, that actually sounds more like maybe a TFCBT thing first
Mhm.
before even
Mhm.
getting to it. And again, right, those are things that they're coming in with.
Yeah, yeah, yeah. But this is my first time on here, so I appreciate it. It's interesting.
Yeah.
Yeah.
Yeah, it's a great project. I think the idea is to kind of get a community of providers kind of to be here to learn from each other
Yeah.
and see what works.
Yeah,
Yeah.
love learning from one another. It's all teach, all learn. It's
Mhm.
what they believe in, and it does work. So we really enjoy it and appreciate all you
Mhm.
guys do for sure. Does anybody else have any questions or comments? We still have time, not trying to rush.
Well, something I was thinking about for the group, because obviously, with my bias, I was thinking, for example, about common barriers, as what I'm seeing in my clinical experience. But I kind of wondered, are there barriers that maybe you guys are seeing in your clinical experience that maybe, mind you, these lists were never made to be comprehensive by any means, but maybe some other barriers that maybe I hadn't quite put up yet to kind of take from y'all's experience.
I don't know. I just love the motivational interviewing. I know it sounds so simple when we think about it, but it's so important to ask them why and explore that so non-judgmentally. And of all the pattern recognition I think that you end up having when you do this job for a long time, I'm always surprised sometimes by the answers people give me when I take that approach, because it's sometimes stuff you would never consider because it's often distorted or part of their belief system. But how important is it for you to know that? Because sometimes the simplest solution can fix the biggest problem. And I love how you included that. And it's so important, and yet it seems too simple sometimes to remember to do that. But I think that's just so powerful. And I loved your examples and the language and the positive, non-judgmental talk. And it's just, again, just so critical to just remember those simple things.
I think, I think it's something to think about. I think a lot of us, I mean, myself included, I'm not exempt from this. I think sometimes when we go to the doctor for a checkup, you kind of go in already with this attitude of, oh, they're going to tell me this about my blood pressure. I know they're going to talk about what I've been eating lately, and I just had an ice cream yesterday. Right? And we're kind of coming in with this expectation, right? That we're going to be judged. Going back to the principal's office, like, I'm going to get in detention. They're going to put me on this terrible diet, and I'm going to have to give up Choco Tacos, right? Listen, I keep it real, right? And these are things that, that we have to think about. And, if that's happening for us, our families aren't exempt, and kids especially, they know what they want. And they're very honest about what they want. And for us, it's like, oh, it's okay. Like, you can have an alternative, but it's not good enough if it's an alternative. It has to be an airhead. Right? So,
Not making me hungry.
sorry.
Go ahead, Heather.
Sorry.
I have a question. And you made me think of some previous clients that I had, and the parents respond to our recommendations in their treatment plan. And what would you recommend for a parent who is like, well, let's say severely impacted child on the spectrum, very limited communication,
Ooh.
only will eat the chicken nuggets, or, only
Yeah.
will wear the purple shirts, and, very rigid. And the parent is, I just can't get them to do it. Or how do I add a new food to their diet? What would you recommend? Like, what is your take when there's a like very rigid child and the parent just
Oh, I love
limited?
feeding questions. So one, I think a little bit of education will help, right? Multimodal. So for starters, it can take up to 60 presentations. And this is for a kid who's not on the spectrum. It can take up to 60 presentations for a toddler to accept that something is simply on the plate. Right? We haven't touched
60,
it.
wow.
We haven't licked it. We haven't anything. It could take as many as 60 presentations just to accept that it's there.
That's a
Right?
lot. I really,
It's
when
a
you think
lot.
about how many times you feed a child, like 60, I mean,
Right?
that's a couple of months, right?
Right?
Yeah.
So, we have to also be empathetic and let them know that that's why consistency is going to be so important. Look, he may not be wanting to bite the thing now, but we may have to just simply start with, let's get him to just accept that it's on the plate, or accept that it's even near the plate. I actually had a feeding thing that I did with a kid with autism, and first we had to present it on a separate plate. And then eventually we moved it to actually being on the plate. Then we started with actually picking it up and touching it. Then, are we going to smell it? Are we going to give it a kiss? Yep, I've done that. We give it a kiss, then a lick, maybe a taste. And then as that keeps going on, okay, maybe we're going to start with a dime size piece, and then get to nickel, then get to quarter, then get to however the parent normally cuts it up. So for them, it's also to understand, like, look, this is going to be a while. We get that he's rigid. It's going to take some time. What are your barriers? And really also maybe get to some understanding of the parent. Like, you know what? At this point, my hair's been torn out so many times from the temper tantrums. I'm really afraid to have another one. Okay, how can we support you? Is this something that maybe we can refer ABA services? Because this is exactly the sorts of behavioral types of interventions that they do. And only do these exposures when you have the support staff in the house. So having them understand, one, feeding, I know, is its own. I think that's why there's now an entire section of psychology just devoted to feeding issues. But, right, so how can we tolerate them? And oftentimes also it may need a multidisciplinary approach. So for example, this kid is very rigid, right, and has a very limited repertoire. Do they have sensory sensitivities that maybe they're going to need maybe additional OT for? Or in terms of speech therapy, are there oral facial muscle difficulties that make it so that, you know what, I can't have these other food textures that are harder than a chicken nugget? And kind of putting those pieces together. And that's why I always like to include, like, I think everyone always thinks, oh, it's some manualized intervention that's going to work for everybody. No, sometimes these interventions may be referring them to the right place. Maybe they do need OT services. Maybe they do need speech. Maybe ABA services if it really is that power struggle and behavioral issues, because with ABA, you know they're going to be very consistent.
Yeah, that parent education piece, definitely. You mentioned that earlier. I think that's a good play on it. And it kind of ties into what Dr. Swagger said, with the motivational interviewing, really finding out where the parent is and where their level, of understanding and acceptance of where their child is, and meeting their child where they're at to start.
I always tell the parents too, like, look, I have an advantage. You are there with your child 24 hours a day, 7 days a week. And maybe I'll see them, if it's more frequent, like once a week out of those 24/7, right? You are tired. I am not. And that's why it's going to look different. And being able to empathize and at least understand the fact that, I get that you are tired. You have an entire life to lead, maybe other children to take care of or other family members to take care of, along with this behavioral issue. And I think opening it up and taking that same stance with the parents as well, or caregivers or grandparents or whoever is caretaking, as well as the child or the adolescent, can also open up a lot. Maybe you're going to find out that maybe caregivers have certain beliefs as well, that, oh, you know what, we tried everything before, it's not going to get better. And that may be worth having a look at. Why is that? What's happened to you before?
Very well said. Thank you so much, Dr. Laura, and such great comments, questions, and discussions. Seriously, guys. We only have 5 more minutes. Is there any other closing remarks or questions you guys have? All right. Did the echo pause? You guys have been great today. I just have one announcement, and that is our next session will be on September 7th. I can't believe we're in September. I'm not gonna lie, I'm a fall lover though, so I'm ready to go. And Amanda Newhouse will be discussing family dynamics and treatment. So that'll be
Wonderful.
really fun. So yes, we hope you guys can make it, and please reach out if you need anything. And I just saw Dr. Laura included her email there. And you can copy that or reach out.
If you guys have questions, something came up, want to troubleshoot, I love talking about this stuff. So if you ever need to reach out, my email is in the chat.
Appreciate that so much. Thank you. And you all have a great day.
Have a wonderful day, guys.